For many patients, the opioid crisis is a crisis of care, one that leaves them feeling abandoned. My name's Phillip Coffin. I'm an internist, infectious disease, and addiction medicine specialist. In my years of practice, I've inherited hundreds of patients prescribed opioids for pain. In most of these cases, I wouldn't have started opioids. In many, I'm not very comfortable continuing opioids. I've had failures. Patients have stormed out of my office, cursing my name. But I've had successes too. Patients whose pain improved, patients who tapered off of opioids, patients who switched to buprenorphine. I'd like to offer a few suggestions on how to manage these situations, how to stop the crisis of patients feeling abandoned, while also protecting your own ability to practice medicine. As always, these suggestions do not constitute medical or legal advice, but are for educational purposes only. First, it's critical to take on the care of these patients and not to judge them. Patients who lose a provider can quickly get labeled as problematic. They might be bouncing around trying to find someone willing to prescribe their medications. Most prescription monitoring programs create alerts for just this kind of behavior, so a patient quickly goes from looking fine to looking like a problem. Second, absent a very compelling reason not to, please refill any opioid medications and even benzodiazepines that a patient is taking and which are due when you first see them. These medications cause tolerance, and running out can be terrifying or even physically hazardous. This isn't just my advice. The new CDC guidelines say basically the same thing, and if you hang on for a minute, we'll talk more about how to do this while still protecting your own practice. Third, develop a patient-centered plan. This can take time and requires a strong patient-provider relationship that doesn't magically appear after one 15-minute visit. The plan might involve a taper, or it might not. Remember that tapers carry risks as well, including use of street opioids, disengagement from medical care, mental health crises, overdose, suicide, and others. These risks are well documented, and there are plenty of papers in prominent publications you can refer to, including this image from the New England Journal of Medicine. You can find more references at the end of this talk. If you do pursue a taper, empower the patient. Let them decide what to taper first and how fast to go. If a patient is on a very high dose, the taper may take years. There may need to be pauses. Some tapers may need to stop. That's okay. Consider any reduction a success. When a patient is actively engaged in a taper, they usually end up with similar or even improved pain. Fourth, if a patient has an opioid use disorder, start talking about medications right away. There are 3 long-term medications for opioid use disorder treatment, and they all help prevent overdose and other bad outcomes. Buprenorphine is a particularly good option for many patients with comorbid pain and opioid use disorder. It's a partial agonist with a high affinity for the mu-opioid receptor, so it actually protects your patient from overdose even if they continue using other opioids. And as of 2023, you no longer need any special license to offer buprenorphine. You can start today. Just like with any other new medications, a great place to start is by taking on the care of a patient who's already prescribed buprenorphine. Fifth, document what you do. Good documentation goes a long way to protecting you from scrutiny and allowing you to provide the care that you think is likely to result in the best possible outcome. Make sure you document the pain you are treating and what's been tried. A risk assessment or screening for opioid use disorder, urine drug screening, checking the prescription monitoring program, some type of informed consent, and naloxone provision. You might even mention in your note some of the data on the harms of stopping opioids if you feel the need to justify continuing therapy for a particular patient. So that's it, 5 steps. Be part of the solution by taking care of patients who have lost their providers. Refill their medications when you first see them, unless you've got a really good reason not to. Work on a patient-centered plan. This is the part that takes time and trust, and be sure to give the patient power in that process. Check for an opioid use disorder, and if you find one, make sure the patient has access to medications like buprenorphine, which any of us with a DEA registration can now provide. And finally, document what you do. That's really important so you can keep doing it. The opioid pendulum swings hard, from gross overprescribing to a fear about prescribing at all. This has left a lot of patients in the lurch, especially when their doctor is no longer available. It's a crisis all around the nation, but we can be a solution. We deal with crises all the time. We're doctors and nurses and pharmacists. It's what we do.